Hi everyone. So today we have another subspecialty VMR, and this time we will be focused on pulmonary critical care medicine. And for that, we have Dr. Montemayor and Dr. Mustafa. Both are from Johns Hopkins, and also Dr. Furfaro from Bethesda Area Diagnostic Medical Center. I would love if they could introduce themselves, tell the reasons why they choose pulmonary critical care medicine as a specialty, and talk a little bit about what they took for fun outside of medicine. Why don't you go ahead first, Dr. Montemayor?
Perfect. Thanks so much, Rafa. My first name is Kristina. As you said, Montemayor. I'm currently a second-year faculty at Hopkins, and I feel like Dave will say in his lung of lungs, so I got that saying from him. So I do adult cystic fibrosis, and then I also do some inpatient oncology ICU time. So those are two of my favorite things, and I'm actually on service right now with Dr. Mustafa. So this is fun. We've had a pretty good Monday, I would say, on the team. And the second question I will answer is what I like to do for fun. I love sports and I love football. I'm from Texas originally, so I am a huge Dallas Cowboys fan, but just love NFL. So I'm excited about playoffs and Super Bowl coming up. And we'll talk a little bit more too about Pulm Peeps, but super excited to have started that with Dave Furfaro, who you'll get to meet a little bit more. And I think really we just wanted to provide a platform for pulmonary and critical care medicine. I think both of us mix a little bit of each, and we both like pulmonary and critical care aspects, and we wanted something that people can listen to kind of anywhere and anytime is what we've said. So and we've had a fun time doing it, and looking forward definitely to more collaborations and more topics that we can send your way.
Amazing. Thank you. Dr. Furfaro?
Yeah, hey everybody, I'm Dave. Really excited to be here and be joining. I do pulmonary critical care at Beth Israel, and I do, as Monty said, my lung of lungs. I do a whole mixture of things. I do critical care, I do ECMO, I do pulmonary hypertension, I do some medical education, research, and other projects outside of Pulm Peeps too. So sort of a mix of everything. I think you asked why we chose Pulm Crit. And I think for me, it was that typical story of like, come for the critical care, stay for the Pulm. You know, when I was a resident, I just got good advice of just think about the days when you leave the hospital and had absolutely like the most fun. You're like, oh, that was the best case and the best day. And that was always in the ICU for me. And then I've grown to love the outpatient pulmonary clinic as well. Outside of medicine, I am also a huge football fan, although I'm a Buffalo Bills fan. So today has been a rough morning day. And then the standard things, movies, reading. I think the one other thing is I'm like totally addicted to chess. So anyone who's been on rounds with me knows that I'm like also playing chess games, unfortunately, but I'm trying to break that habit if I can.
And could you talk a little bit why you guys created the Pulm Peeps and what is intended for?
Oh, yeah. Kristina said it very well. You know, I think that we both just sort of love these topics in pulmonary critical care. And you have so many interesting conversations, you know, be it in noon conference rounds, just like rounding on somebody with your team. And I think podcasts have been a great platform for that. And, you know, clinical problem solvers, curbsiders, we know some of the cardio nerds guys, and we just didn't see one that was doing a lot of the pulmonary, a lot of critical care, but we thought we could augment that too. And so we just wanted to have something where we could have these cool conversations, invite people on to sort of share their thoughts and share it with everybody. We hope people are enjoying it.
Yeah, it's an incredible podcast. Congratulations. Really, really awesome.
Thank you.
Dr. Mustafa, could you please introduce yourself?
Sure. Hey, everyone. I'm Ali. I'm one of the first-year pulmonary critical care fellows at Johns Hopkins. I'm in my clinical year. And like Dr. Montemayor said, we're working together in the oncology ICU this week. I chose pulmonary and critical care really because coming into residency, I just loved internal medicine so much. And I wanted to specialize, but I didn't want to lose, you know, that knowledge of everything. And I found, honestly, that pulmonary and critical care gave me the opportunity to learn a lot about everything and to kind of be good at it all. Well, hopefully I will be one day, but that's kind of the plan. What I do outside of work for fun, it's tough in the clinical year, but I'm trying to do a lot more cooking. I actually made croissants for the first time this weekend, and they came out delicious.
Oh, wow. Yeah, we are foodie here at CP Silver, so we love to talk about food.
Good, good. I'll have to show
Um,
you guys some pictures later.
Yeah. Oh, Ali, I got to
love
build
to
on
see
what you
that.
said because I like really liked that thinking about everything too. And I remember I was talking to a friend when we were choosing our specialties, and I was like, oh, like wouldn't it just be so sad that you never think about like plasma cell dyscrasias again? And he was like, no, I never want to think about that again. I was like, oh, okay, I should do something broad.
I would love if who's doing teaching point today? Is it?
That's me.
Oh, Brody, please introduce yourself.
Oh, okay. Hi. Hi, everyone. I think people really know me, but I'm Brody. I am calling in from California today. It is, again, I think people have listened to me a lot doing teaching points. I think people should be getting bored, but in case you are, I'm sorry. But it's very excited and I'm looking forward to the case as well. Yeah.
Thank you. Who's describing?
Maria, she's
Oh, Maria, please introduce yourself.
Hi, I'm scribing. My name is Maria. I'm located in Guatemala, and I'm really excited to do this.
Yeah, and we have our supervisor, Jack. Please, Jack, go ahead.
Oh, I am far from a supervisor. I am a learner and a very excited participant today. My name is Jack. For those of you who I haven't had a chance to meet, I'm one of the other CP Solvers team members, and I'm just stoked to get to expand my pulmonology knowledge today. That's a lot of G's for me, so I apologize for stumbling over that. But yeah, super excited for the case, and really looking forward to learning with everybody. I might chime in with some questions that my novice pulmonology brain needs some help with, potentially after some of the aliquot discussions. Yeah, look forward to getting to hear what you all have to say about the case.
Awesome. Could you please share the screen review? Dr. Mustafa, whenever you're ready, you can start.
All right, so our first aliquot is going to be really brief because I want it to be a lot of discussion. So I'll start by just telling you that the patient is a 46-year-old woman who's coming into the hospital with shortness of breath and cough. And I want to just hear what the experts have to ask about that.
Me too. Please go ahead, expert.
Yeah, so I can start, I guess. I mean, even just with that brief, you're starting to have some thoughts percolate. And I think any disease comes down to the disease you're thinking about and the substrate it's in. So, 46-year-old woman, you're starting to get a picture of this patient, certainly not making any assumptions on somebody who is young or not having health problems or anything like that. But those are the kind of the questions I'm going to be asking about. And then shortness of breath and cough, very, very common presenting symptoms. And so I think somebody even put in the chat, tempo is key. I totally agree with that. The first thing I want to do with these is think about acute versus subacute versus chronic, because it's going to start activating some frameworks that I have. So my first question is just, how long has this been going on, and then why is the person presenting now?
So it's been going on for a little over 1 month. And she's coming in now because her son found her on the ground having syncopized after walking a little bit in the house.
Cool. And that's an unbelievably helpful thing for me, because all of a sudden this seems much more, acute than it could be of just shortness of breath and cough in the clinic that, she was found down after a syncopal episode. So already started getting me thinking.
Please go next, Dr. Montemayor.
Yeah, and then just to add on to what Dave mentioned, when I hear shortness of breath, I always like to ask, is it shortness of breath with exertion, or is it shortness of breath with exertion and rest? Because I think that could also shape your differential a little bit. And then also getting more information with cough. Like I said, I do adult cystic fibrosis, so I see a lot of productive cough in patients that I see, but I know that's not the case. So when thinking about cough, definitely thinking, is it productive or non-productive? And then I think timing wise is also important. I know things I was taught as a first year fellow when thinking about cough is timing of the cough. Does it wake them up from sleep? Does it occur more in the morning than in the afternoon? Does it occur with any food intake, potentially concern for aspiration? So those are some things that I'm thinking of, at least right now. I know Ali will get more into history in just a minute, but those are things off the top of my head.
Yeah, so she does have some shortness of breath at rest, but it's exacerbated significantly by exertion. There's no association with food or drink. She doesn't cough after meals or anything like that. She doesn't know or doesn't really remember when the cough happens. It just kind of comes on and off all throughout the day. In terms of the nature of the cough, it started off productive for a few days, but then persisted as a non-productive cough for the rest of the month and continued to go throughout her hospitalization.
And I'll leave with the productive. Was it a certain nature of the productivity? Was it hemoptysis, would certainly do, because anyone, was it just white or clear sputum, green or purulent sputum, anything that she can remember about it?
Yeah, it was white clear, no hemoptysis, no purulence or greenness to the sputum when it was productive.
And then
how does the fact that this patient has like productive cough change your diagnosis? Like, is there a framework for that? Like, as a medical student, sometimes I struggle with that. Like, what do I have to think when a patient presents with productive and non-productive cough?
Yeah, that's great. I think for me, when I'm thinking about shortness of breath and I'm thinking about coughing, first of all, we're thinking about these things combined. So when someone has an isolated cough, I have a whole other differential that's going. So when these things are combined, I really often focus on the shortness of breath, and we'll get there, but if hypoxemia as well. And I think about with a cough, is there something that's going on in the airways or in the alveolar spaces that's really triggering both of these symptoms to go? And so what I'm getting at with the characteristic of the cough is trying to answer that question a little bit. And so, at the extreme of it, if they're coughing up blood or clots, then I'm worried about blood in the airway, in the alveolar spaces. If they're really thick, green or yellow sputum that's changed, then I'm thinking about more infectious inflammatory causes. And then dry cough, I'm thinking about things that are either bland, like fluid filling, or maybe just an airways disease that is causing irritation and coughing without something that's actually filling the spaces. But I think I can see if Kristina has any other thoughts about that as well.
Yeah, no, definitely agree with you on that, Dave.
Kristina, could I also ask? I really appreciated you highlighting that the shortness of breath with exertion versus at rest can be like a helpful branch point in terms of the evaluation. What types, or like, I guess, how does the way that you're thinking about shortness of breath change when you get the added qualifier that it might be exertional?
Yeah, that's a great question. And when I think of shortness of breath, at rest versus, with exertion, so shortness of breath at rest, sometimes I tend to bring in, potentially not only like pulmonary, but versus, cardiac etiologies as well. As I know we're pulm peeps, but Dave and I think about the heart as well. So that can definitely change that for me. In addition to that, and I know there's been a couple of people coming in with chats specifically, like, pulmonary hypertension in the setting of syncope and dyspnea at rest. So, we could be potentially going that pathway as well. Or so that's kind of how I see it. It makes me think of, dyspnea on exertion, I think could be a little bit more generalized things, maybe not as, malignant things that we're thinking of with dyspnea at rest, definitely more concerning things are maybe more acute, and would expect to see some findings either on imaging and or echo that may help lead to an answer with that way.
That's super helpful. Thank you.
You're welcome.
I think an additional question I have, Ali, is we talked about the tempo and, this being over a month, I'd be curious over the month how things have progressed. And then I also like to get a sense of, people often underestimate their shortness of breath and how long it's been going. So I like to find out when the last time they could really do their exertion, their normal level was. And so sometimes I'll say, how far can you walk and when could you walk last Christmas? But I like to give like a date, so if they say a month, then I say, so 2 months ago, you were going up the stairs, no problem, carrying your groceries. And sometimes they say, yup, absolutely. And sometimes they say, oh, no, wait, I haven't done that in 2 years. And so I like to ask, about that. So be curious about her. And then if it is a new episode of this, has she ever had anything like this before? Or is this sort of the first time she's ever had symptoms like this?
Yeah, that's a great question and really important for this case. So she was feeling completely normal before these symptoms started on Thanksgiving Day. Actually, she remembers the day when she started to feel unwell. Prior to that, she could go up and down the stairs without issue. She can do all of her daily chores. She can go out for walks at any distance without any issue. And then slowly over the course of the months, things progressively got worse. They were really bad in the very beginning when she was having that purulent cough. I guess not purulent, but when she was having that productive cough. But then after those 5 days, it got a little bit better, but then steadily, slowly, but surely got a lot worse. And she was evaluated by her primary care doctor several times during that month. And they tried different things like different antibiotics and stuff like that. Not to kind of get into the weeds a little bit, but that's going to come out, I'm sure.
And I think that's important, Ali, to specifically, I know you'll get into a little bit, but just, what has been done, what's worked and what hasn't worked. And I know someone put up a great question or a great comment in the chat as well that, potentially you can have mimickers, and specifically that the patient didn't respond to antibiotics, how that may change things. So I'm excited to hear you talk a little bit more about that coming up soon.
Yeah. So her PCP did prescribe her a 5-day course of azithromycin after they noticed. I'll give a little bit more detail into kind of what brought her into the hospital, but they had checked x-rays in the outpatient setting and found multifocal infiltrates. The PCP gave her azithromycin thinking she had a multifocal pneumonia, didn't respond to that, tried a different course of antibiotics that she doesn't remember, and a repeat chest x-ray showed similar findings. And that's kind of also why she came in addition to that syncopal episode that she had.
That's super helpful. And I think with antibiotics and thinking about someone who has gotten them and has not gotten better, I think of, a couple different categories. Either it's not an infectious disease and we've had the wrong diagnosis. Either it is infectious disease and we have the wrong bug. We have the right bug and it was the wrong duration or the wrong intensity, or there's some factor that makes them more likely to have this infection that's making it hard to clear. So someone put, post-stenotic, but like a post-obstructive pneumonias, or they are immunosuppressed, so they're having recurrence. So those are kind of how I go through it. I think one thing a lot of people have been putting in the chat, and I totally agree with this, she syncopized now too. So now not only do we have shortness of breath and cough, so I would be curious about other associated symptoms, that we're going through. Is she having chest pain? Has she had lightheadedness before? Is it worse with the exertion? Is this the first time she syncopized? And trying to get a little bit better history about that portion of the presentation as well.
Yeah, so it is the first time she syncopized over the course of this month, and she doesn't have issues with syncope throughout her life otherwise. What was I going to say? So the syncopal episode is pretty new. I'm slipping. What else were we talking about? Sorry.
No. And then whether or not, I think that's helpful because, if it was, it can be a first thing for any of the cardiac causes, but, you think sometimes people with pulmonary hypertension or a cardiovascular cause of all three symptoms might have a little lightheadedness every time they exert themselves. And it might not be a brand new symptom as opposed to something that's presenting. And then, chest pain or lower extremity swelling, things like that would be other associated symptoms I'd be curious about.
Yeah, so she did not have any chest pain. She did not notice any lower extremity edema. Her main associated symptom really is just profound weakness and fatigue. And she can't really pinpoint where the weakness is. She just feels general fatigue. And again, it's been going on in progressively getting worse over the course of the month. But again, no chest pain, no lower extremity edema. I talked a little bit about the cough already. No lightheadedness, no dizziness.
I would love to ask the experts, like if I try to combine syncope and a pulmonary cause, what would you tell me are the most common reasons a pulmonary etiology leading to syncope that no one should forget about?
I mean, I would say that, for Dave probably enjoys this more, but I would think, PE definitely could be a pulmonary and cardiac cause that could cause syncope that we definitely shouldn't miss. And I know that's been brought up in the chat as well. So I'm glad people are thinking about that. Yeah,
I think PE has to be number one on that differential. Pulmonary hypertension, outside of PE causes is another classic presenting complaints or a presenting issue, and something that we always ask about in the review of systems. And then I'll just go, I will push though that we think about that a lot, but somebody who is hypoxemic and having increased work of breathing, or septic, which are often associated with these infected, can often present with sort of systemic symptoms like it sounds like she does. And then that can lead to syncope. So I think it's important to think about PE and pH in someone who presents like that and do a thorough evaluation, but not to anchor on it, because I think sometimes that can be misleading. If someone's really been struggling to breathe, then this can happen as well.
And what are the clues in the history that you take that you're dealing with a pulmonary hypertension cause?
Yeah, so I can go over that one. I think a couple of the things that we always ask about are some of the things we've been talking about here. So we're talking about the tenor of their shortness of breath and dyspnea and when it comes on. Pulmonary hypertension almost always is worse with exertion. You have a impaired diffusion, and then you also have worsening when you have to have increased cardiac output. And so that is a telltale sign. Whether or not they have reproducible or ongoing lightheadedness and syncope with exertion would certainly be a warning sign. Also, other cardiac symptoms like palpitations, chest pressure, or pain when they're having those, I would be more worried about. And signs of right-sided volume overload. So they may have some weight gain, abdominal distension, lower extremity edema. And then finally, I'll say, I don't want anyone to take this as too much of dogma, but cough is unusual in pulmonary hypertension alone, primary alone. Now, if you have another cause like interstitial lung disease, which is very common, then cough happens a lot. But, just a new cough like this, especially if it was in the absence of other symptoms, makes me a little less suspicious for it at times.
Incredible. Thank you for your thoughts.
Mm-hmm.
Ali, I have a couple of other clarifying questions that if you can add to. One, I'm just, has she had any recent night sweats?
No night sweats.
Okay. And any type of, I guess, like skin rashes?
She does have a rash, but she reports that as a chronic rash and has followed with a dermatologist.
Okay. Can you do you know kind of where what limbs are involved, or what that, can you describe
on her
anterior?
Yeah, it's on her anterior chest and on her back, kind of midline. And it kind of comes and goes. It's intermittent. And again, she's seen a dermatologist. She doesn't know what the diagnosis is. She's gotten some creams for it in the past.
Okay.
Yeah, that's interesting. I think, right away, my first mind, you always have a diagnostic brain that just sort of looks for patterns, which we sometimes have to silence, but we sometimes have to listen to. But I think, shortness of breath, cough, and rash over her chest, like, is this dermatomyositis? Is this like a shawl sign that we're having that's going, or another inflammatory condition that could be causing this as well? And then you said no night sweats, but any other fevers, chills, like other infectious signs that she's been having? She got antibiotics multiple times, so just curious.
She never measured her temp, but in that first few days, she did feel hot. And I'll just add that she did have some sick contacts a week prior to these symptoms, some viral illness running around the family. No one was tested for COVID though, nor was she in that time. I see a couple of really good questions in the chat too that I'm just going to answer real quick. Anne-Marie Comfort asks about sun sensitivity. The patient didn't report any issues with the sun. And Vivek asks about occupational exposures. No exposures to new animals, plants, chemicals, and she doesn't have any work with asbestos or silica or beryllia or anything like that.
Yeah, and I think at this point, people are getting at some of it is, I think there would be more review of systems and more going over some of her shortness of breath and cough, but I'd also be curious to know like who she is in the world. She's 46. Is she healthy? Is she on meds? What is her status before all this?
Yeah, I think that's a perfect segue into our next aliquot, if that's okay. I'll fill in a little bit about her past medical history, surgical history, social history, and everything like that. So her past medical history is notable for type 2 diabetes. Her sugars at home are typically in the 300 to 400s. She also has hypertension. She also has a diagnosis of hepatic steatosis. In terms of surgical history, she only has a tubal ligation after the birth of her second child. She has never history of tobacco use, vaping, alcohol, or any illicit substance use, intranasal or IV. She is a mother of 2 adult children, and she used to work as a medical assistant, but has been out of work in the times of COVID. She's been looking for a job. And I'll read off her current med list, and then we can kind of talk about that and see how this all affects our differential for her. So in terms of her medications, she's on Humalog 15 units 3 times a day with meals. She's on long-acting insulin 30 units at night. She's on glipizide 5 milligrams. She's on semaglutide 0.25 milligrams weekly. For her blood pressure, she takes amlodipine 10, atenolol 100, chlorthalidone 50, lisinopril 40, and she's also on a statin, pravastatin 40 milligrams daily. So
how does this new information change the differential, Dr. Montemayor?
Well, I think a couple of important things that I had, and perhaps we should have asked earlier. People were thinking about, one, just the shortness of breath and cough, any tobacco exposure, which doesn't seem like, is she an active smoker that could have potentially, changed things, or does she have some underlying, obstructive lung disease? But it doesn't seem that at least she has triggers for that. And then anyone coming in with a cough, we see this sometimes in pulmonary clinic, not necessarily associated with shortness of breath, but definitely someone coming in with a cough, we always ask medications. One, are there any new medications? And then 2, specifically thinking about lisinopril or ACE inhibitors, where you can sometimes see a cough associated with use, which she's on. But again, I wouldn't necessarily think that the lisinopril would cause the dyspnea on exertion or the syncope. So I would think that would be less likely. But so those are 2 things I pointed out based on what Ali told us about meds and history.
Dr. Furfaro, do you want to add something?
Yeah, I think it's just like a very helpful history. As we're going through the HBI, I'm always sort of in my head actively sort of building and adjusting a problem representation. I see you guys have a box for that even, but it's as this person comes in, I'm thinking of a 46-year-old woman who's coming in really with like subacute cough and shortness of breath that's been worsening over the course of a month, now coming in with syncope, refractory to multiple courses of antibiotics, and some generalized systemic symptoms. And like, 1, 2, and 3 for me is still infection. It's a little bit atypical, but because it's been getting worse, not getting better with antibiotics. But infection, common things being common. And then you're adding this diagnosis of type 2 diabetes, hypertension, hepatic steatosis. She is not maybe you're not your absolute typical 46-year-old, and maybe a substrate for worsening infection. Sugars in the 300 to 400 are certainly not well controlled, and we underestimate how much of a immunosuppressive state diabetes can be at times. And so I'm thinking about, again, common causes of infection are the most common, but then a little bit of atypicals as well coming through. Fungal, some bacteria that you might not see always in the community, like some other gram negatives and Pseudomonas in people that might be more likely to get it. I think someone put in the chat here about the immunosuppression of diabetes. I don't think about PCP, I don't think that they have enough immunosuppression to indicate that, but I'm still thinking infection is most likely, and now I'm sort of broadening my differential for what those pathogens could be.
Someone asks on the chat, where does this patient from? Where is this patient from?
Yeah, she was born and raised in the Baltimore area, really.
Awesome.
And she hasn't had any recent travel.
It's a good question, though.
Yeah, people are concerned about endemic mycosis. Do you have the physical exam, Dr. Ali?
Yeah, I can go into the physical exam if we don't have any more questions about her past medical history. I see, just to kind of fill in some of the blanks, she has no known allergies and her family history is not really relevant. She has some like cardiovascular disease in her family, but that's about it. I think the keys here are she's got pretty poorly controlled metabolic syndrome derangements. I can go into the physical exam because I think this is where things might change a little bit here. So her temperature in the ER is 36.3 Fahrenheit Celsius, not afebrile. Her heart rate is 89. Her blood pressure is 160/88. Her respiratory rate is 20. She's satting 87% on room air at rest. and it goes down to the low 80s, high 70s with any ambulation. And she requires 3 liters by nasal cannula to maintain adequate saturations on room air. In speaking with her, she's in no distress. She's actually speaking in full sentences. She has a normal cardiac exam. Her lungs were clear with no crackles or wheezes, but she did have tactile fremitus on the right side increase. Her belly was soft, non-tender, non-distended. Her neuro exam was normal, and the rash is a maculopapular rash that's mostly in her anterior, on her anterior chest and in her back. And it's kind of, I would say some of them are pustular, but not all, very few of them are. No lower extremity edema, her JVP is flat.
As a medical student, sometimes I struggle with the concept of hypoxemia. So how do you think about like etiologies, potential etiologies for hypoxemia? Like as a medical student, how would you explain that to me?
Sure. So, I mean, I think that we think about sort of the 5 common mechanisms of hypoxemia that occur, and I still kind of go back to that, and those a mechanism of hypoxemia encapsulate lots of different organ functions that are not just the lungs, but also cardiac hematology. So, we think about hypoventilation occurring. We think about low partial pressure of oxygen, which we see very uncommonly, unless you're, up in the Himalayas or things like that. We think about shunt VQ mismatch, and then impaired diffusion. And to work those things up, we often would end up needing an ABG and thinking about an AA gradient, with our elevated AA gradient being the shunt VQ mismatch in impaired diffusion. I'll say that the diffusion here certainly can't be normal. So she's 87% on room air, which means that she, even at rest, has some VQ mismatch, right? In that she's not totally matching up her perfusion and ventilation because she's hypoxemic, even just breathing room air, which she shouldn't be. But then when she ambulates, she goes down to 80%. So that's she's significantly dropping enough where I think that her syncope could be something pathologically related, but can just be, if you drop very low while you're walking, can make anybody lightheaded. And so I'm sure she has some impaired diffusion with this as well.
And how the patient responds to oxygen, how do you change your differential?
Yeah, so I think that you're talking about shunt versus VQ mismatch, right? And so if you have a pure shunt, they're going to usually increase a little bit to oxygen, but they're not going to have as profound effect as you would imagine. And so you sort of, think about this in the most extreme version of it, where you don't have any ventilation there, you're just shunting right to left. And that happens, you would worry about that quite a bit in someone with syncope, pulmonary hypertension, if they had a right to left shunt, that could happen. And then if you do respond, then you're really thinking about VQ mismatch or diffusion abnormalities.
Amazing. Dr. Montemayor, anything to add?
No, nothing to add to what Furf mentioned, but I have a couple of other things I wanted to see if Ali had on as far as physical exam that I would think about. I mean, one thing I wanted to point out, and I think based on our episodes, I think Dave and I always mention, so if someone can't speak full sentences, I think that's very alarming, and can kind of change acuity of things. So I think the fact that even though she's hypoxemic, she's speaking in full sentences, she's not necessarily in so much distress where, she may need an ICU level of care or, non-invasive assistance with that. But things I wanted to ask Ali, as from a pulmonary perspective, when we're thinking of things, does she have any clubbing present?
She does not have any clubbing.
Okay. I mean, I think usually with clubbing, sometimes we can see in a more chronic hypoxemic condition. And then we've talked about pH a couple of times here throughout. Does she have any evidence of a right ventricular heave on exam?
So she did not have a right ventricular heave. Her S1 and S2 sounded pretty normal.
Okay.
I didn't hear like an accentuated P2 or anything like that.
Okay. And I think just looking at the pulmonary exam, no crackles and specifically no wheezing. I think if we were thinking this was more of an airway problem, asthma or COPD that could be leading to this without any type of wheezing, that would be a little bit abnormal as well. So those were things that I'm not exactly sure what to make of the rash at this point. Is it related? Is it not related to what we're seeing? But I think definitely important to point out.
Yeah, and then I think with this, there's a sign here on our pulmonary exam with the tactile fremitus. I'd be curious, like the other things that go along with that, right? So it sounds like they have sort of increased, transmission of vibratory sense when they're feeling there, which could think about consolidated lung. And that means that consolidated lung is right up against the pleura and the chest wall, not a pleural effusion with fluid in between. But I'd like to do some confirmatory things for that. So I would listen in that area and listen up to see if I have decreased breath sounds there. Then I would probably do some techniques like agophony, have them say E and see if the transmission of that sound changes. And then I think that percussion for the pulmonary exam is probably like the thing in physical exam that we should do on everybody that we skip the most often. And we just actually had a guest on Pulm Peeps who was saying how when she starts the pulmonary exam, she percusses to find the bottom of the lung first and then listens up. And I just think that is like a wonderful habit to get into, because your percussion would be better and better. And then also you really are listening to the full lung fields. But assuming those things go along with tactile fremitus, which is usually a pretty specific finding, I'd be worried now about a patient who has presenting with this shortness of breath and cough and a consolidation. I don't know if there was one area of the lung where that happened, Ali, or was it, one distribution?
Yeah, I felt that the increased fremitus was more pronounced in the right middle area,
Okay.
but otherwise it was okay.
And then, this rash, it sounds like she had a rash before. Unclear if this is related or not, because she's been seeing somebody for it a little bit. But, and I'm not great at rashes, right? So macular, pustular, like I think what I take when I see someone with rashes like this and a systemic symptom is I'm really just thinking about infections and inflammatory conditions. And then I like to try to do a little bit more research, which is always a good thing to admit. Like, I don't know, and I need a little help with this one. But I think about, tick-borne illnesses, viral illnesses most commonly come with viral xanthoms like this. And then, inflammatory conditions like a vasculitis or any connective tissue disorders often are like lupus and things like that often have a rash associated with them as well. So I'm sort of honing in on those things from our exam a little bit.
And I could actually ask you both. It seems like I think one of the things that is striking is sort of the one hypothesis of like the hypoxia pulmonary hypertension pathway, and then this other hypothesis of like the consolidations plus or minus rash. And I feel like for me, cognitively, a lot of the things that we might put in the pulmonary hypertension bucket wouldn't necessarily be consolidative processes. And I'm curious, like, does the finding of consolidations, does that feel like it potentially adequately explains the syncopal episodes just by virtue of the degree of hypoxemia? And then if that doesn't fit, are there, like, if you all sort of like map the overlap of consolidations plus pulmonary hypertension, are there things that are in that differential for you all?
Yeah, I agree. I mean, I think that it is a little bit separate, thinking more of the consolidation, to me at least, and I'll definitely see what Dave thinks as well, but the consolidation doesn't really fit the pH pathway. So, it'd definitely be interested, and we'll get to some imaging to see what Ali shows with that. But I'm thinking of them kind of as two separate processes. So is it just, does she have so much consolidation that were the hypoxemia in and of itself caused the syncopal episode? Because we're not seeing anything on physical exam wise to kind of support pulmonary hypertension at this time. So is that more of an outlier based on what we have so far? But interested to see what Dave thinks as well.
Yeah, no, I think you guys nailed it. I mean, I think it's so apt, right? This is where I feel like the interesting stuff about being a diagnostician comes in. And I think anchoring is this huge pitfall we fall into. Like, we hear syncope and shortness of breath, and like pulmonary hypertension is now high up on our list. And really nothing else we've seen sort of fits it. She's not having weight gain. She's not having palpitations. He doesn't have predisposing conditions, no family history, She's hypoxemic, which again, hypoxemia and pulmonary hypertension, usually pretty advanced. And even if like a right to left shunt would be very advanced, no RV heaves, no jugular venous distension, no edema. So like that's pretty, it's, moving lower and lower. And I feel like I'm focusing on the consolidation now. And then one big thing that we haven't done on the physical exam, we've done an ambulatory O2 sat, which is like, unbelievably necessary part of a patient like this, but we haven't done orthostatics. And so someone who comes in syncope with this type of history, orthostatics might answer your whole question right there too. So I feel like they're rarely done in the ED, but another key physical exam maneuver that should be done for her if we could get it.
And which labs would you most be interested in right now?
I think definitely, so I think anyone coming in with shortness of breath or dyspnea, I think we still have to exclude anemia, even though we think it's less likely. So, but I would be interested. And so one, is she anemic? So we'll get a CBC for multiple reasons. One, to check for anemia, but also to check for potentially leukocytosis. Would want a diff as well. Just when thinking of broad pulmonary conditions, does she have any lymphopenia? Does she have any eosinophilia? So CBC with diff would be something I would want to start with.
Dr. Furfaro?
Oh yeah, sorry. I think this is like with labs in general. I feel like anybody who comes in, we're gonna get at least the CBC and CMP. I'm curious with the syncope and this type of history if she has a little creatinine elevation, a little AKI. I also have like if her creatinine is significantly elevated and she has a rash, then I'm thinking about like pulmonary renal syndromes and systemic inflammatory syndromes, which I think are really important. With the rash and consolidation as well for LFTs, there are certainly like atypical infections that I think more likely about elevating LFTs, Legionella. In Baltimore, there was always this, people always were worried about leptospirosis in Baltimore because the rats apparently have leptospirosis in Baltimore, which is something I learned down there. But like, things about your typical pathogens, but looking for, signs of abnormalities that can sort of focus me a little bit more. So, CBC, CMP, I love to get an ABG on these people if I can, like we talked about, although a little bit uncomfortable for the patients. So we don't always do that. And then, based on those results, then I would start thinking about other like inflammatory markers, vasculitis markers, but I would probably get a little bit more workup and imaging first before jumping to some of those tests.
Perfect. So I'll go into kind of the preliminary workup before we got involved as pulmonary. So in the ER, her initial labs were notable for a white blood cell count of 8,000, 66% PMNs with an ANC of about 5,000, 22% lymphocytes, and 1.4% EOs with an absolute eosinophil count of 110. Her chemistry was normal. Sodium was 138, potassium was 3.4, chloride was 96, bicarb was 26, BUN was 12, and creatinine was 0.4. They did have LFTs that were normal. And early on, I'll just say, because it was asked in the chat, she had an HIV test that was negative. She had 2 COVID swabs that were negative. And she had tropes and tropes that were negative as well. And I'll save the rest of the more exotic labs for after we got involved. And I will say that her hemoglobin being 16 is a little bit above her baseline from a year ago.
So what do you think about this new information, Dr. Montemayor?
Yeah, so I think the anemia standpoint, we can definitely rule that out. She doesn't have a severe kind of leukocytosis, so potentially like an occult infectious process, normal kind of PMN range that we would expect. And I'm just trying to see other things too. Yeah, I think having normal CMP, including the LFTs, I think can kind of exclude some of the things that Dave brought up as well. Yeah, immune status in her was definitely important. And I think with a negative HIV, we could think some things would be less likely, some potentially less atypical infections, et cetera. And then, yeah, negative troponin, so less likely for a cardiac etiology or cause.
I wonder if you could think that her elevated hemoglobin could be to the fact that she's hypoxemic. Like maybe this process has been long, a chronic process has been long going on, you know. Is this right to think about that or not?
I think that's a great point, Rafa. I don't know if or Dave or Ali, were y'all going to say something?
No, go ahead.
No, I think that's it's a great point to bring up. Yeah, I mean, it'd be interesting to kind of trend what her hemoglobins have been. Is this just kind of a spurious one? You know, are potentially, you know, we didn't see necessarily findings with elevated creatinine, but sometimes, you know, do we have any reason to think that she may be hemoconcentrated? So would be interested to kind of see what her trend would be from that.
Yeah, I totally agree. Is this, you know, my first question with this in a presentation is this true erythrocytosis? You know, do they have, is there just hemoconcentration? You know, no creatinine elevation, but, you know, by our exam, she certainly doesn't seem wet, but maybe she'd be dry a little bit. And then if it is erythrocytosis, then I start thinking more, is it primary or reactive? And, you know, is this hypoxemia more long-standing that has been causing this? And Kristina asked some great questions before that made me think like somewhat less clubbing, no clubbing, things like that. But other people, I think, have mentioned in the chat as I'm glancing as it goes by, you know, with her metabolic syndrome, we actually don't have a weight yet or a BMI, but does she have OSA, which would be like a very common cause of chronic hypoxemia and erythrocytosis, and then, you know, starting to work down that differential as well. And I think you know, Monty said, but the normal white count is really just an interesting thing. It's making, I was saying how infection was highest on my differential, but, you know, I think it's much less likely she has like a bacterial you know, a pneumococcus pneumonia right now with the totally normal white count. It's possible, but less likely. And I'm starting to think about what causes infiltrates that are not infections, like inflammatory causes. And I see her EOs, you know, that's essentially normal. You know, anything above 100, I start, you know, 150, I start thinking if they could have an infiltrative disease, but there's nothing remarkable there that really stands out to me.
Oh, I really love the pearl about creatinine. Thank you.
I will say that I cheated a little bit. I put this as the first hemoglobin. Her hemoglobins throughout the hospitalization were just in the normal range. I thought it would just spark a good conversation. I will say that her differential was the same throughout the hospitalization. And I realized I didn't give her BMI. Her BMI is 35. So she is a little bit, she's definitely obese. And one question was, it asked if the PCP checked her pulse ox. In this world of COVID that we live in now, both of those visits were video visits, and she had the chest x-ray scheduled outpatient. So she didn't have any vitals.
A question that I have with this BMI, would you think about like obesity hypoventilation syndrome or maybe obstructive sleep apnea in this patient?
Yeah, I definitely think that's worth considering. And I know Dave potentially, you know, mentioned that as well. But I think that could be a reason for potentially having some hypoxia, but I wouldn't necessarily think of it causing kind of this dry cough that she's had, and less likely to be kind of a main trigger for syncope as well. And I think, you know, hopefully we'll see some imaging soon, but I think, you know, the tactile fremitus that we saw and the potential concern for consolidations wouldn't be associated with those conditions either.
Any thoughts, Dr. Furfaro?
No, yeah, I definitely think you'd be at risk. I think, and we could look into it, but I wouldn't, you know, wouldn't change my overall differential about where I am for her kind of causes. You know, maybe from her baseline. And I'm still now with my problem representation, I'm focusing on evidence of consolidation, likely on exam, in the setting of her, you know, her dyspnea and productive cough that's converted to dry. And so when I'm thinking of causes of consolidation, so that could be doing this, you know, infectious, which we think typical is a little less likely, inflammatory, and then her age is young, not a lot of risk factors, but certainly if she had malignancy or a mass that then was causing an associated compressive consolidation or a post-obstructive, that would be on the differential too. So those three big buckets are where I'm thinking right now. I'll be looking for evidence, trying to cross them off or corroborate them when we do get imaging for her.
All right, perfect. So maybe I can segue into more of the data. I'll start with an EKG and then I'll go into some of the other imaging that she got in the ER. I'm going to see if I can take the screen share. All right, let me give this a shot. Okay. You guys see my screen?
Yes, we can
Yes,
see it.
we do.
All right, don't read my notes. Oh, whoops. All right, so I'm just going to go ahead and interpret this EKG. I think it's important to review the EKG in all cases, this case especially, because we're definitely thinking about cardiac etiologies and our differential. And it's important to go through it systematically. And I think having an approach is always very helpful. So what I like to do first is it fast or is it slow? I can't do that whole box thing, so I end up counting all the RRs and then multiply by 6. So that turns out to be about 75, 80 beats per minute on this EKG. Then you ask yourself, is it wide or is it narrow? It's narrow. We want to ask, is it sinus or is it not sinus? And my trick for that is the P wave up in 1, up in 2, down in AVR. So I would argue that the P waves are coming from the sinus node because they're following that same axis. And then we also look to see if there's a P wave before every QRS and if there's a QRS after every P, which you can say that there is. So far we have it's a normal sinus rhythm with a narrow complex. Then we look at the intervals. And the one thing that I notice here is this PR interval is not prolonged or anything, but the P wave is a little funky. It's a bifid P wave. And I've learned of this as something called an M mitrale, because it looks like an M, and it could be one piece of the puzzle to signify left atrial enlargement. It's shaped like an M. I can explain the physiology of it on a later date if anyone's interested. But and to kind of quantify it, you want the peaks to be about one small box apart. And I would argue that yes, that is the case. And then we also look at V1, and it's a biphasic P wave in V1 going down pretty deep, 1 millimeter. So I would argue that there is some left atrial enlargement here. Then we want to look at the ST segments. They all look okay. I don't notice any significant ST elevations or ST depressions on this EKG. There are findings consistent with left ventricular hypertrophy by the Cornell criteria, adding up the R wave in AVL and the S wave in V3. If it's greater than 20 in a woman, in a female, then that's consistent with left ventricular hypertrophy. And the last thing I want to comment in this EKG is I see some poor R wave progression. You want the R wave to start taking over at around V3. And in this patient, it's not doing that. And that could signify left ventricular hypertrophy, right ventricular hypertrophy, ischemic heart disease. I don't think this is an EKG consistent with someone with a history of ischemia, but it suggests that there's something funky with her heart. And I think that's important in our differential. I can move on to the chest X-ray, which I think is a good one.
Oh, before we even go to the chest, there was one thing I wanted to mention that I thought about before I didn't say, if that's okay. On the physical exam, we were mentioning the feminist and the locale, and I think Ali, I know, does a very thorough physical exam, but for everyone to notice is like, we said right middle, but you have to be specific on like right middle lung field in the back, because to listen to the right middle lobe, you really have to be on the side and anterior, right? Very little, mostly none of the right middle lobe is touching the back. So, it's really important on your exam to listen anteriorly as well. And it's because we get different anatomic distributions. And so it just helps you trigger of like where I'm going to look when this scan comes. So just a reminder for everyone.
Yeah, great point. It was on the back, but in the middle of her back.
Right. And then
Right.
I think somebody said left anterior fascicular block here, which is really nice because of the QR in 1 in AVL and the RS in 2, 3 in AVF. But I don't think there's actually a left axis deviation because 2 is upright. And so someone correct me if I'm wrong, but so I don't think it actually meets criteria, but that's really nice in seeing that pattern of QR and R in the lateral and RS in the inferior.
Great. All right. I'm going to move on to the X-ray.
And I can take a look at this one. And hey, and Rafa, just for time wise, are we okay with time?
Yeah, we usually have 1 hour, but it's totally fine to go over, no problem.
Okay. Great. So so we're looking at a chest X-ray, both PA and lateral, and I know we don't always get to both lateral. Sometimes we just get an AP view. But when I'm looking at the X-ray, just a couple of things. You know, is it a good film or not? So I'm looking at the penetration, and I like to see the vertebral bodies behind the heart borders. I would say overall good penetration. I look at rotation, so I want to make sure that the spinous process are in between the clavicles, maybe slightly more towards the left clavicle than the right clavicle, so potential rotation there. And then I look at inflation, and I really look at the posterior ribs. When I looked at this initially, I thought there might be some hypoinflation, but I'm counting at least 8 posterior ribs, so let's say overall normal inflation. And then going through ways, I know everyone may interpret things differently, but I kind of use the ABCDEF method. So A for airway. So looking here at the trachea, which I think is midline. I see the carina and their bifurcation pretty well there. So B for bones, you know, I think that sometimes could be harder to differentiate. I think we're on the CT.
Sure.
You know, worries. I don't see any bony abnormalities. I know one of our radiologists on our radiology rounds can like tell if someone has multiple myeloma just by looking at the chest X-ray, which I cannot. But I don't see any gross bony abnormalities. C for cardiac, I'm looking to see, can I see the heart borders clearly or not? I think there is some obscurement on both sides. So when I think that the right heart border is slightly obscured, I'm thinking that at least there's some type of right middle lobe involvement of the underlying process going on. And the left one, I can pretty much make out. I think the question, you know, that we're having is there any evidence of cardiomegaly? And with a PA and lateral film, we can call that. You know, I don't have a ruler, but it's probably, you know, it might be right at about 50%. So, you know, I think definitely this would be someone that we would get an echo in anyways, just to further look at cardiac function based on what we're hearing so far. So D for diaphragms, I go to next. We expect to see this kind of right diaphragm elevation compared to the left side. I look at the, you know, the costophrenic angles, crisp or not. I can see them on both sides. And if there's something obscuring it, you might think that there's an underlying effusion, but I don't think it's grossly abnormal. You know, and then E is kind of for everything else, which I know leaves a lot. And when I'm looking at things, I like to see, you know, what is there a parenchymal process going on? And I like to comment, is it bilateral? Is it bilateral or not? So I would say there is a bilateral process going on. I would say overall it's diffuse because it looks pretty broadly covered. You know, maybe the APCs by apex 6 bilateral may be somewhat preserved, but I would say diffuse bilateral opacities. And I'm saying, you know, different opacities on both sides, I like to think, is it more of an alveolar process versus an interstitial process? When I'm thinking of more of an interstitial process, it's more linear. When I think of the alveolar process, I think it's kind of more fluffy or cloudy, as some people like to describe it. So I would say overall, this is a diffuse bilateral alveolar opacities that are noted on the PA film. And then looking here at the lateral, again, you see that too. You see, you know, this alveolar process that's going on. It's kind of impacting the spine, so potentially some, you know, spine sign with that. And I think differential is going to be broad at this time, but, you know, Ali, I do our radiology conference on Fridays, and Ali has become a pro in differential for alveolar processes, but basically thinking kind of a pus, water, blood, cells or underlying malignancy, and then not necessarily common, but it was one of our last radiology rounds where we think of protein for pulmonary alveolar prognosis. So I think we potentially with this image will be good to see what the CT shows, but I think we're at least thinking of an alveolar process that's going on. So still potentially infectious, inflammatory, or the other reasons that I said.
Absolutely. Spot on. And now I'll move to the CT. I took a few slices of it.
Dr. Furfaro?
Yeah, I can take a look through a CT, and certainly, CT, looking at a CT sort of active process, usually scrolling up and down. And I encourage people to have a system just like Monty did for the x-rays, but for CAT scans. So, I usually look at quality of, is there movement, inspiratory or expiratory phase? Is there any metal that are disturbing my images? We can see here, Ali's pointed out, this probably nice inspiratory phase because the trachea is nice and round. So that back flexible wall of the trachea collapses on expiration and is more D-shaped. But just using these slices, I like to think about the characteristic of the infiltrates and then the distribution. So this distribution, from what I can see is multifocal. It looks like it's in all 5 lobes. I can already see bilateral lower lobes, right middle there, upper lobe. Yeah. And so I think probably all 5 lobes. We're describing it as multifocal. Definitely consolidative opacities, especially on that sort of like bottom left image. You can see some areas there where the air spaces are filled. Can't see through them at all, not just ground glass. So multifocal consolidative opacities. And then I see some air bronchograms going through them, speaking with the consolidations. And then in other distribution, there looks like it's sort of peribronchovascular and maybe just some bronchial thickening sort of throughout, which can definitely be infectious. Bronchitis or bronchopneumonia of any etiology will have sort of that bronchial thickening, and then non-infectious causes, asthma, I think most classic. Other obstructive lung diseases like CF and ABPA, although no evidence of cystic dilations here. And then cryptogenic organizing pneumonia classically causes some, bronchial airway thickening as well with consolidations and sometimes some nodules. And maybe I'm seeing a little bit of nodules like on that top right. I'd have to scroll through and look, but maybe some of those are like consolidative nodular opacities in that distribution as well. So based on this, I'm thinking, and I don't see any pleural effusions and things like that. My infectious inflammatory is like way higher still, right? So those are our 2 big categories, and that's where I am now. Is this a pathogen, an atypical pathogen, or is this an inflammatory, probably, lung disease like connective tissue associated or evolving interstitial lung disease, cryptogenic organizing pneumonia, acute eosinophilic pneumonia? That's sort of where my mind is going.
Great. And I just cut some sagittal and some coronal just to kind of, again, show the distribution and so show some more air bronchograms in different distributions, different angles. So again,
Yes.
You can just see it's in all lobes. All right, I'm going to give it back to you guys for the screen, and I will talk a little bit about when we came along. So the team were concerned by these imaging findings and by the history and by the patient's persistent hypoxemia. So they consulted pulmonary to evaluate kind of for, again, as we were all thinking, infectious versus inflammatory processes. When I saw the patient, I got the history, we were thinking kind of along the lines of everything that we've already been discussing. Cardiogenic is obviously high on the differential. She's got poorly controlled diabetes. She's got poorly controlled hypertension, maybe some LVH on that EKG. But we recommended a BNP, which was completely normal, and an echo, which actually was completely normal as well. We were thinking about infectious, but it was a little lower on the differential given the lack of white blood cell count, the low neutrophil count, and everything like that. So less likely to be infectious. So we were thinking a lot about inflammatory pneumonias, and we ended up recommending sending some rheumatologic markers as well as getting a bronchoscopy, BAL, and a biopsy. Now, do you guys want to talk a little bit about that, and then I'll go into our results?
Sorry, Ali, were you asking, what was the question?
Oh, I guess I'll keep going kind of for the sake of time, and then we can discuss in the aftermath. But So
but yeah, I think briefly, I agree with everything that you were saying, that this is the time that I would send sort of this broader inflammatory labs to sort of rule this out, like in sort of infectious etiology you're saying. But then, this is like you mentioned, when we're talking about airway opacities, if you could think about empiric treatments, but I want to know what's going on in the lungs. And like, we have a way of doing that. So like, I want to look in the lungs, I want to send a sample for cell count. You want to take a biopsy if I can, just so I'm not guessing so much. I kind of know what I'm looking for here and what I'm going to be treating.
Yeah, for sure. So we did recommend some inflammatory markers. She did have an elevated CRP slightly to 1.7, an ESR of 35. She had a normal CK, and interestingly, her aldolase was elevated at 42. She had normal ANA, normal CCP, normal ANCAs, normal rheumatoid factor, SCL70, RNP, and myositis. So a lot of the more specifics were negative. And a peripheral workup for fungal infections with galactomannan, beta-D-glucan, blastomycosis, coccidio, and histo were all negative. We went on and did a bronchoscopy, and the bronchoscopy cell count showed some white cells with 84% lymphocytes, no eosinophils, 14% neutrophils on that. And she had, again, the same infectious workup sent, and it was all completely negative. And we performed a biopsy. I'm just going to take over the screen share one more time. I'll reveal the diagnosis. The patient was eventually diagnosed with cryptogenic organizing pneumonia based on this biopsy. And we recommended treatment with a long course of steroids. It was a difficult choice because of how poorly controlled her diabetes was, but oh Lord. But that's kind of what we recommended, a prolonged course. I'm having some technical difficulties with a few things I want to highlight on this pathology slide real quick. It's always interesting to kind of look at the tissue. One thing that you see is thickening of the alveolar membranes, as well as these things that the arrows are pointing at, fibroblast plugs. Unfortunately, this is a stock photo that I stole from the internet, but this is kind of what was reported on our biopsy. So the patient was diagnosed with cryptogenic organizing pneumonia. Again, was discharged on a long course of steroids, and I'm actually going to see her in clinic next week.
Oh, incredible case. Thank you so much. Just one last question, Dr. Furfaro, Dr. Montemayor. As for medical students and trainees, what do you think it's important to remember when thinking about COP?
Yeah, well, I think one thing is important. I've seen a couple of cases of this too, and it'd be important. Ali, I don't know if you had repeat imaging or not, but one thing that I've seen, and specifically in this one patient case that I remember, and I think that's you kind of remember cases that you never forget, and she had like migratory actually opacities. So she had like 3 admissions to the ICU, would always get cap coverage, wouldn't improve. And then every time she came in, we were able to like chronicle them, and she would still have alveolar opacities, but they would be in different spaces each time. So I think that's one thing that I would definitely remember or evaluate if you have interval imaging. I think on exams, sometimes you can hear, I know some of our senior faculty will always ask, do we hear kind of an inspiratory squeak? Which I maybe have heard one time, but that's maybe some classic teaching, or some faculty may ask about that. And then I'll just say 2 more things, and I'll let Dave kind of jump in as well. But when you're thinking of cryptogenic organizing pneumonia, it's kind of a diagnosis of exclusion. So I think of bronch in this sense, bronch, and then assuming transbronchial biopsy in this sense made perfect sense, because you want to basically exclude other big categories before saying that it fits with more of a COP. That's more of a idiopathic or primary. There are some secondary organizing pneumonia cases as well. And then the last thing is, it's usually, it can affect men and women equally, usually in the 50s to 60s. So, she was maybe a couple years younger than what we would expect, but I think overall kind of fit the category with that. And I want to make sure Dave has time to talk as well. So I'll hand it over to him.
No, I mean, those are amazing points. And I think one thing we went through quick with the time is just sort of the BAL cell count. And I think that's something people should remember. It can be a very helpful tool, in a typical CAP, like bacterial caused pneumonia, you would think about a neutrophil predominance. Eosinophils over 20% in a case like this are going to be diagnostic of acute eosinophilic pneumonia, which is very similar to COP and something that has to be ruled out. And then a lymphocyte predominance, in sort of acute inflammatory consolidations like this, you start thinking about interstitial inflammatory lung diseases as long as there's no infection underlying that. So I think about that. And then I just echo what Monty said. I think it's the two biggest things is that there's a delay in diagnosis in COP. So you have to have a high index of suspicion. People are often treated multiple times with antimicrobials. But with that a high index of suspicion, you also have to remember it's a diagnosis of exclusion unless you have a biopsy. So biopsy seals it, but COP is often made clinically when they're just not getting better on multiple courses of antibiotics and they're tried on steroids and improve. So, balancing those two factors. And then finally, high recurrence rate, high relapse rate. So the steroids go for, months at a time, usually at least 6 months for the initial course with some very slow tapering. And there's a high rate of it coming back if you taper too quickly. So just a disease that definitely needs follow-up.
I just want to thank everyone who joined us today. Thank you, Dr. David. Thank you, Dr. Montemayor. Thank you, Dr. Ali. Such an incredible and educational session. And now to finish this off, I would love if Brody could do the teaching points.
Hey, hi. Oh my gosh, that's such a good case. Yeah, I think we're kind of running out of time, so I'm going to touch on a few broad points. So, I wanted to say, when you have shortness of breath, think of a cardiac, pulmonary, chest wall, neuromuscular, hematological causes, and don't forget the pleura. So cough, productive, non-productive, time of the day, food intake, other external causes like drugs. Are you thinking of upper and lower airways? Also keep in mind vagal irritation. I'm kind of using the schema from CPS. Antibiotic failure. Think if it's non-infectious causes like this, or wrong bug, wrong drug, antibiotic compliance, issues with the tissue like penetration issues or natural history, it's too bad of a bug or it's too soon. So then hypoxia, the hypoxemia schema was look for a normal AA gradient or impaired AA gradient. You won't have it, but kind of think of the causes to be in that order. So normal AA gradient, hyperventilation, asthma, COPD. Impaired, look for a pulmonary exam. If you feel it's normal, think of the vasculature. If it's abnormal, think of the pleura and the parenchyma. Then a few quick points: chest X-ray, quality check, inflation and rotation. I look for the ABCDEF, A for airway, B for bones, C for cardiac, D for diaphragm, E for everything else, which includes parenchyma, alveolar processes. Alveoli can be filled with pus, water, protein, and blood. And then interstitially, you could have interstitial things are really a little fluffier in quality, I guess. And then CT, again, quality check. Look for if there's any metal, inspiratory and expiratory phases, and focality. If it's multifocal or, in particular one lobe, and if there's anything wrong with that. And location, if you see bronchial, vascular, or alveoli. Look for contrast if you have, but also make sure you use the natural contrast with air. And then look for the pattern, as well as do not forget the pleura. So then by a few points about COP, thickening of the alveolar, I think I kind of made some mistakes here, but with subepithelial fibrosis, goblet cell hyperplasia, I wrote from the slide. And think of migratory opacities if you have serial scans. Inspiratory squeak, and it's a diagnosis of occlusion, mostly diagnosed on a bronch biopsy. 50 to 60 years, equal predominance between male and females, and try to learn the BLC cell counts as well. Yeah, so I guess that wraps it up.
Thank you, everyone.
Thank you so
Hope
much.
everyone have a good night. And this was an incredible session. Thank you all for coming.
Thanks for
Bye.
having us. Appreciate it.
Yeah.
Thank
Thanks,
you.
guys.
Everyone.
Have a good night.
You too.